Good morning, everybody.
Morning.
All right. Today's topic is qualitative description of normal gait. I would consider this to be foundational knowledge that sadly has dropped away from most curriculums in resident training programs. There's a tremendous amount of material and information in this talk, and quite frankly, I don't think you can hear it once and get it all. That's why it's available for you on the folder that you saw. You're welcome to go back to it, look at it, take it home, whatever you want to do with it. All right. Here are my disclosures, none of which are really relevant to this particular talk. I am happy to be interrupted at any point if you are not clear on what I'm talking about or you want to take a deeper dive into the topic. But here's the goal of this talk. I want to introduce you to fundamental concepts of normal gait, introduce you to some of the common terminology that we use to describe gait. At the end, though, I hope you'll have a new appreciation of the biomechanical elegance of human bipedal gait. And then we'll talk a little bit about the relative roles of qualitative versus quantitative gait analysis. So we recognize that there is a gait cycle. The gait cycle is a period of time. It goes from the initial contact of the reference limb when that foot first hits the floor to when it hits the floor again. So that is the gait cycle. We divide the gait cycle up into two subphases: a stance subphase, which is when the reference limb is in contact with the floor, and a swing subphase, which is when the reference limb is not in contact with the floor. The events that define the intervals between these two are called initial contact. That's probably the most comprehensive term, so that's the one you would want to use. And then the transition from stance to swing relative to the reference limb, we describe that as toe off. We further divide the gait cycle up into 4 subphases in stance and 3 subphases in swing. The first and fourth subphases of stance are periods of double support. That means both limbs are in contact with the floor. The middle 2 subphases are periods of single support. That means only the reference limb is in contact with the floor. Swing phase is divided up into 3 subphases based on the orientation of the tibia or shank segment relative to vertical. Now, what we're going to do is go through each of these subphases, and I'll try to highlight the key elements. And to do that, we'll use this diagram of the gait boy. We'll go through all the subphases of stance and swing. The joint centers will be shown by solid green circles. The muscles that are active at any particular subphase will be highlighted in red. And then the location of the ground reaction force will be shown by the yellow arrow. Here's one of the take-home messages from this talk. At any instant in the gait cycle, there needs to be a balance between externally applied forces and internally generated forces. In stance phase, the ground reaction force is the principal externally applied force. In swing phase, there's no longer a ground reaction force, but there are gravitational and inertial forces that come into play. Internal forces are generated primarily, but not exclusively, by the muscles. They can also be generated by ligaments, joint capsules, and skeletal anatomy. The location of the ground reaction force in stance phase relative to the joint centers is carefully controlled to optimize efficiency of gait. And it is controlled by a combination of muscle activity and body segmental alignment or posture. So let's begin. The first subphase of stance is called loading response. It lasts from 0 to 10% of the gait cycle. It is a period of double support, so both limbs are in contact with the floor. The body center of mass is relatively low and moving forward relatively quickly. The principal tasks here are shock absorption and load transfer. Notice that by the end of the loading response, the location of the ground reaction force relative to the joint centers is such that there's a lot of muscle activity required to balance things out. That will become significant in our next lecture when we talk about how gait is impaired or disrupted in kids with CP. The second subphase of stance is called mid-stance. It lasts from 10 to 30% of the gait cycle. It's a period of single support, so only the reference limb is in contact with the floor. By the end of mid-stance, the body center of mass is high and moving forward along the line of progression relatively slowly. What is happening here is an upward progression of the body center of mass. And this is achieved by having the foot flat on the floor and the hip extensors, which include the gluteal muscles and the hamstrings, firing to extend the hip. Now, you might think that when the body's center of mass is at its highest point in stance phase, that would be a period of maximum potential instability, and that would require a lot of muscle activity to balance it out. However, that's not so. If you look at the location of the ground reaction force relative to the joint centers, it is such that only one muscle group is active, the ankle plantar flexors. So that would be a window into the underlying energy efficiency mechanisms associated with human bipedal gait, which as a consequence, we all walk the same way for energy efficiency. So whoever designed this, a brilliant design. The third subphase of stance is called terminal stance. It lasts from 30 to 50% of the gait cycle. It's a period of single support. So again, the reference limb is the only one in contact with the floor. The body center of mass is high and moving forward along the line of progression slowly. And what we have is a forward or downward progression. This is a controlled falling forward. And again, you would think, this has got to be a time of maximum potential instability, a lot of muscle activity required. But again, you would be wrong. The only muscle group active are the ankle plantar flexors. Now, when we consider the moment generated by all of these muscle groups in the gait cycle, the largest moment generated by any single muscle group at any point in the gait cycle is generated by the ankle plantar flexors in terminal stance. As a consequence, disruption of ankle plantar flexor function, a ruptured heel cord, has an enormous consequence on disrupting typical normal gait. Okay, so remember that the ankle plantar flexors are motor number one in the gait cycle. The final subphase of stance is called pre-swing. It lasts from 50 to 60% of the gait cycle. It's a period of double support, so both limbs are in contact. It's a period of double support. So both limbs are in contact with the floor. The body center of mass by the end of pre-swing is relatively low and moving forward relatively quickly. And what's happening here is a preparation for a phase shift from stance to swing of the reference limb and from swing to stance of the opposite limb, and load transfer from the reference limb to the opposite limb. So notice that the hip flexors are active, starting to pull the thigh segment forward. As the limb is unloaded, the ground reaction force falls behind the knee joint center, creating an external knee flexor moment. And this is our first clear clue as to how the knee works. In stance phase, what happens at the knee is controlled primarily by what happens at the ankle. In swing phase, what happens at the knee is controlled primarily by what happens at the hip. The knee is a couple between the ankle and the hip. And the activity of the muscles that cross the knee play a very small role in actually moving the knee. As a consequence, if there is ankle plantar flexor dysfunction, there will be knee deviations in stance phase. If you have poor hip flexor function, your knee probably is not going to bend very well in swing phase. And that will become very important again in the next lecture when we talk about CP. Now, again, if we consider the magnitude of the moments generated by these different muscle groups through the gait cycle, the second largest moment of any muscle group at any point in the gait cycle is generated by the hip flexors in the stance to swing interval. And a very close third are the hamstrings in the first part of stance. So the hip flexors are motor number 2, followed closely by the hamstrings and hip extensors. All right, so 3 very important muscle groups. Let's move into swing phase. The first subphase of swing is called initial swing. It lasts from 60 to 73% of the gait cycle. It's characterized by acceleration of the limb and functional shortening of the limb. The combination of hip flexion, knee flexion, and ankle dorsiflexion functionally shorten the limb. The thigh segment is being pulled forward by the hip flexors. The limb is no longer in contact with the floor, so there's no ground reaction force, but there are gravitational and inertial forces holding the tibia or shank segment back, and the knee flexes. All right, so the knee is not bending because of muscle activity across the knee. It's bending because of what's happening at the hip and the gravitational and inertial forces. All right. As we walk faster, the excursion of the shank segment becomes greater and the knee flexes more. And that takes longer for the shank segment to eventually catch up. All right. So if you're dealing with somebody, a child who is an above knee amputee, when they're really little, we give them a single axis constant friction knee, quite simple design, and they figure out how to walk with it. And as they start to walk faster, the knee bends more quickly and has greater excursion, and they can't get the prosthetic limb through quickly enough in swing phase. So what they do is hop back on to the stance limb again, okay? As they get older, we give them a more sophisticated knee design, one that has variable resistance to flexion based on the rate of loading. It's called a hydraulic knee, okay? The rectus femoris is the biological equivalent of the hydraulic component of a prosthetic knee. So as you start to walk more quickly, the rectus fires to limit knee flexion so that you can pull the shank segment through more quickly and you don't have to hop. It's interesting that we call the quadriceps, okay? If we go back to Vesalius and Da Vinci, they were sneaking into cemeteries at night, taking bodies, opening them up, and then having to put them back. So when they opened the thigh up, they saw a muscle that had 4 parts, so they called it the quadriceps. As our understanding of anatomy improved, it became clear that 3 of those heads crossed only the knee joint, but one of them crossed the hip and the knee joint. That's the rectus femoris. As we got more sophisticated and started measuring dynamic EMG, so the electrical activation of muscles during the gait cycle, it turns out that the timing of the 3 heads of the gastroc that only cross the knee is completely different than the timing of the activation of the rectus femoris. So functionally, we've really got 2 muscle groups, the rectus femoris and the triceps femoris. And why they don't teach it that way is beyond me. So we have to sort of unlearn all of that to bless you, to really understand what's going on. Okay, everybody good? Initial swing. The second subphase of swing is called mid-swing. It lasts from 73 to 87% of the gait cycle. We have a shift from the joints flexing or dorsiflexing to extending. And it turns out that our body's proprioceptive sense, So you see that the hip flexors are turned off now. The thigh segment is not moving forward not being pulled forward more quickly. The shank segment overcomes gravitational and inertial forces. It starts to move forward and the knee extends. Again, the knee movement is not a consequence of muscle activity across the knee. Our ability to know where our body is in space is exquisite. And in swing phase, even walking on uneven ground, we can clear to within a centimeter. Think about when you have temporarily lost your proprioceptive sense. Typically, it's stepping off a curb that you didn't know was there. It's very, very disorienting. Well, unfortunately, there are children with CP who have impaired body position sense. And so you can imagine for them, walking could be quite difficult. And we'll talk more about that in the next lecture. The final subphase of swing and the final subphase of the gait cycle is called terminal swing. It lasts from 87 to 100% of the gait cycle. It's a period of deceleration, so the limb is slowing down. And the principal task here is to pre-position the limb for the upcoming initial contact. And when everything goes right, it's the heel that hits the ground first. So heel strike at initial contact is what we desire. And if we look at the gait boy here, we see a lot of co-activation across the hip and the knee joint. That means muscles that do opposite things are firing at the same time. And that is done to perfectly position the hip and the knee for the upcoming loading. And you can also see that the pre-tibial muscles are active here as well. All of this is required to achieve a heel strike at initial contact. I think terminal swing is an understudied subphase of the gait cycle. It's pretty fascinating what's going on, and there's a lot of muscle activity, many two joint muscles firing. That means muscles that cross two joints. A very interesting subphase. All right, congratulations. We just built the gait cycle. As we increase the speed of our locomotion, we change the manner in which we move. And we recognize three movement patterns. One is walking, the next is running, and the next is sprinting. Now, these represent categorical classifications of what is probably a continuum. And not everybody does exactly the same, but there are some things that we want to point out. So on the top here, we have the walking gait cycle that we just went through. On the bottom is the running gait cycle. Notice that the duration of stance phase in running is less than it is in walking, and that there are only 2 subphases in stance instead of 4. And we still have a heel strike at initial contact. The duration of swing phase in running is longer than in walking. And notice that the 2 periods of double support from stance phase in walking are gone in running and have been replaced by 2 new subphases in swing called double float. That means neither limb is in contact with the floor. So on the left is somebody walking, and they have a double support. On the right, we now have double float. Now on the top, we have the running gait cycle, and as we move even more quickly, we transition to sprinting. The duration of stance phase in sprinting is even shorter than in running. And now we have a toe strike instead of a heel strike at initial contact. So the main differences between running to our left is that there's a heel strike at initial contact, whereas in sprinting, there is a toe strike. We don't know exactly why this is. There are thoughts relating to just getting the stance phase limb through the even shorter stance phase and putting the ankle plantar flexors in a muscle in a position to do their job under a significant time constraint. So you get rid of the first rocker and you go right to somewhere between second and third rocker. All right. There are a variety of ways that we measure how we walk. And one type of data are called time distance or temporospatial parameters. And these include, as you see, velocity, cadence, stride length, and step length. Velocity is distance per unit time. And for our purposes, recognize that velocity is the product of cadence and stride length. And again, as we move into disruption of gait, that will become significant. Of all the different things that we measure in the gait lab, all the different types of data that we collect, it's probably the temporospatial parameters that are most closely linked to function and probably to patient satisfaction. And think about it, right? The whole goal of life is to keep up with everybody else in terms of walking. That means you got to have a decent speed. All right, second take-home message from this talk. To achieve a normal gait pattern, you have to have stability in stance, clearance in swing, effective phase shifts from stance to swing and swing to stance, and all of this has to happen in a relatively energy-efficient fashion. And it turns out that normal gait is remarkably energy efficient. And as all of you know, we measure energy efficiency by considering oxygen consumption and carbon dioxide production energetics. So when we do energetic analyses, we learn that walking requires less than twice the oxygen of sitting or standing. As a consequence, any deviations from typical are associated with an energy cost. So fast walking increases energetics requirements by 60%. If you are a below the knee amputee, so one major joint replaced mechanically, the ankle, the energy cost is comparable to fast walking. If you are an AK, above knee amputee, now two major joints are replaced mechanically, the energy cost is 100%. If you have to use your arms to compensate for weakness or whatever, absence in your legs, it triples the energy cost. How many of you have ever walked with crutches? Is this resonating?
Yeah, of course.
Yeah, yeah. When we think about energy efficiency in normal gait, we would want to consider the concept of muscle length, the role of biarticular muscles, those that cross two joints, the concept of active versus passive subphase stabilization, and limb segment coordination. So let's start with muscle. It turns out muscle length is carefully controlled to optimize muscle function during gait, be it eccentric, which is lengthening activity, or concentric shortening activity. To dig a little bit deeper into this, we need to go back to our understanding of muscle physiology and look at length tension curves for both the contractile component of the muscle tendon unit and the structural component. Contractile components, the muscle belly, the structural components are the tendon, and as it turns out, some extracellular matrix. Anyway, all of us are familiar with the concept of actin and myosin and the overlap of them. If we look at sarcomere length on the horizontal axis, muscle sarcomere length, that's the individual unit of actin and myosin, and we look at the ability to generate tension or force on the vertical axis, we see that in circumstance A, where there is excessive overlap, i.e. the sarcomere is too short, that compromises its ability to generate force. Similarly, circumstance D, where it's stretched and the actin and myosin overlap is suboptimal, that also decreases skeletal muscle's ability to generate force. So relative to length, it turns out there is a specific window between B and C that is ideal for the muscle to be able to generate tension or force. If we now look at the whole muscle tendon unit, all right, so you have whole muscle length on the horizontal axis and the ability to generate tension or force on the vertical axis. If we start at the resting length of the muscle tendon unit and we stimulate it, it can generate a certain level of tension or force. If we put a slight pre-stretch on the muscle tendon unit, that enhances its ability to generate tension or force. Interesting. It turns out that happens in the gait cycle all the time. Let's think about motor number one, the ankle plantar flexors. At initial contact, we would say the position of the knee and the ankle is such that the muscle tendon unit of the gastroc soleus is at its resting length. By mid-stance, the knee is extended, the ankle is slightly dorsiflexed, gastroc soleus on a slight stretch. Perfect, because we need to move into terminal stance and generate that large moment, motor number 1. How about motor number 2, the iliopsoas? At initial contact, the hip is flexed. So we would say that the iliopsoas is probably short. Doesn't matter though, because we're not really asking the iliopsoas to do much. As we move through stance phase, the hip extends. And by the time we get to pre-swing, the hip is extended, stretching the iliopsoas, putting it in the optimal biomechanical circumstance to do its job, generate motor number 2, pull the thigh segment forward as the limb unloads. So again, another really cool design feature. There is also a relationship between the velocity of a muscle's contraction and its ability to generate tension or force. And this, in a simplistic way, is thought to be related to the rate of the cross-bridge attachments between actin and myosin. So when we think about concentric or shortening muscle activity, which is designed primarily for speed function, we see that there is an inverse relationship between force and velocity. So the faster you go, the less the muscle's ability to generate force. Alternatively, eccentric or lengthening muscle activity, which is for strength and stability, we see that force generation is relatively independent of velocity, which is probably a safety feature. All right. So if we put it all together, there's a complex relationship between length, velocity, and the ability to generate tension or force. There is a narrow window for optimal function, and skeletal muscle is most sensitive to high velocity shortening type activities in terms of compromising its ability to generate tension or force. For those of you who would like to take a deeper dive, I would point you to the body of work by this man, Rick Lieber. He's a muscle physiologist, but he's hung out with orthopedic surgeons a lot. And he bridges what we've learned about muscle from lab studies of frogs and relates it to actual clinical medical circumstances. So brilliant guy, a friend, and huge contribution. All right, let's move on to biarticular muscles. These are muscles that cross 2 joints. They function in energy transfer between segments. They coordinate the movement of the limb segments. And examples would be the psoas, the hamstrings, the rectus, and the gastroc. For those of you who have already done seminal surgeries with Dr. Kulkarni or Dr. Whitaker, or some of you from previous rotations with me, you will recognize that these are the muscles that we operate on in CP, all right? We try not to touch the single joint muscles, which are primarily for strength and stability. This is our focus, working on these muscles. There are subphases of the gait cycle that we consider active stabilization. These are subphases that require a lot of muscle activity to balance out the externally applied forces. There are other subphases that we consider relatively passive, that include passive stabilization. And this is where the location of the ground reaction force relative to the joint centers is such that the ligaments and the joint capsules and the skeletal anatomy can generate internal moments to balance out the externally applied forces. So all things being equal, we would like to minimize our time in subphases that require active stabilization and maximize our time in subphases that allow for passive stabilization, again, for energy efficiency. So loading response would be an example of a subphase that requires active stabilization. Mid-stance, a subphase that is relatively passive stabilization. We try to minimize our time in loading response and maximize our time in mid-stance. And next time that we're together and we talk about CP, you'll see that this is totally flip-flopped, unfortunately, in them. All right. When we consider energy efficiency, we have to consider the contributions of photographers to understanding walking and engineers. And I'd like to take a short historical detour and tell you about some of the interesting people who have played a role in our understanding of normal gait. This is a photograph of Edward Muybridge. He was born in England in 1830. He ended up in San Francisco, where he worked as a book dealer. He was on a book-selling tour in Texas in 1860 when he was in a stagecoach accident and sustained a closed head injury. While he was recovering, he developed an interest in the new field of photography. He pretty quickly became one of the preeminent landscape photographers in the US West, and his work rivals that of Ansel Adams, who came decades later and had better technology than he did. The governor of California at the time, Leland Stanford, made his money on railroads. His passion was racehorses. And at the time, there was a debate as to whether, when a horse is running, were all four of the horse's legs ever off the ground at the same time? Nobody knew. So Stanford hired Muybridge to develop a technique for freezing or photographing fast motion. And as you can see from Muybridge's work, he was able to show Stanford that yes, indeed, there is a time where when a horse is running, all four legs are off the ground. Now, although he was hired to freeze fast motion, he learned somewhat serendipitously if he took these frozen images and showed them in sequence at a certain rate, he could recreate the visual perception of motion. And the machine that he made to do this, he called the zoopraxiscope, which you see on the bottom right. And this is what the output of his zoopraxiscope looked like. So he became kind of a rock star. He traveled all over the US and Europe, showing off his zoopraxiscope and these moving pictures. While he was working for Stanford, he studied movement of a variety of animals, and he published that in 1887. And this book is still available, and it's incredible. I mean, anything that could move in the animal kingdom, he attempted to photograph their motion. He also studied human motion and published a book on that in 1901. And again, here's what his output would look like. His human locomotion book had pictures like this, two boys doing a jumping game. To the left, digging with a shovel, the middle throwing a baseball, and then wrestling. Little bit of homoerotic stuff in there, I'd say. Other routine tasks, sweeping to the left, washing clothes. Now we're getting into a little bit of S&M, so spanking the baby, and again, some homoerotic scenes. Buried deeply in this book is this study of a subject who had what at the time was called Little's disease. Today we call it cerebral palsy. And she has many of the gait deviations that we see in our patients today. So the first video study of an individual with CP. Here's a child reduced to a quadrupedal gait pattern. I'm going to guess he had polio. And so he had weakness and contractures at the hip, knees, and ankle. Here's a bilateral AK amputee, maybe hit by a train. That's a good way to lose both legs. Join Dr. Lerman in our limb deficiency clinic, and you will see subjects who have this level of limb deficiency moving exactly the way this young man does in terms of getting in and out of chairs. So 100 years after his death, the US Postal Service had a series commemorating pioneers of communications. And in this series is our man, Edward Muybridge, who is remembered as the father of motion pictures and Hollywood. Good story, I think, but there's more. While Muybridge was working for Stanford, he married a woman half his age, and they almost immediately had a baby. And he almost immediately after that learned that the baby was not his. So he was outraged. In the middle of the day, went into downtown San Francisco to the saloon where the man was drinking and shot him dead. He was immediately arrested, put on trial for murder. His patron Stanford hired the best legal minds in the Bay Area at the time. The trial received a lot of press. It was called the trial of the century. And ultimately, Muybridge was acquitted of murder on the grounds of temporary insanity related to the closed head injury that he had sustained years earlier in the stagecoach accident, establishing a US legal precedent for the concept of temporary insanity. Okay, if qualitative analysis of movement is the domain of artists and anatomists, quantitative analysis is from engineers. I'd like to tell you about these two guys, Braun and Fisher, about the same time, 1890s. They were hired by the Prussian military to study a variety of rifle and backpack designs to see which ones would allow the soldiers to walk in the most efficient fashion. Their technology you see on the screen here, they had a rubber suit. They put long, skinny electric light bulbs over the limb segments, excuse me. They turned off the room lights, they turned on the light bulbs, and they made movies. And this is what their output looked like. They then spent 2 to 3 months measuring the angles between the limb segments to create kinematic data. So this is what they would be working with. A colleague about 15 years ago took their kinematic data and used it to drive an avatar, and it was remarkably accurate. Today, we get the same data real time thanks to computers. If you go back and read Braun and Fisher's work, you learn that it took 3 hours to suit up the subject for the study. And if you didn't get the rubber suit and the electric light bulbs just right, the subject would be electrocuted when you attempted the study. So probably wouldn't make it through the IRB today. The modern era of our orthopedic measurement of movement begins with the work of this man, Vern Inman, who was an orthopedic surgeon. He had a PhD in anatomy. He had his entire career at UCSF. And after World War II, he was hired by the War Department to do research on prosthetic design for soldiers who were returning as amputees. He recognized that we needed a better understanding of normal gait to figure out how to improve prosthetic design. He partnered with engineers from Lockheed who were looking for work as the war effort, wound down, and created the first modern biomechanics laboratory in Berkeley. And this is what the output of his work looked like. Inman recognized that certain segments of the body are best considered as locomotor segments. And we're talking obviously about the legs. These segments have significant dynamic range of motion. It's primarily in the sagittal plane, but it can also occur in the coronal and transverse plane. And again, the lower extremity, it's pretty obvious. But it turns out that the upper extremity can also be a locomotor segment. When you look at Olympic level sprinters, their arms are huge. Why would they carry that muscle weight around? Locomotor segments. When you see individuals with spina bifida or spinal cord injury walking, you will see that they use their upper extremities to compensate for weakness in the lower extremities relative to locomotor segment function. So the arms are locomotor segments as well. Inman recognized other parts of the body are best considered as passenger segments. These have minimal dynamic range of motion. It's measurable if you have a computer, but it's typically less than 5 degrees in all planes. And we're talking about the trunk, the head, and the neck. Clinically, what that means for us is if we're watching somebody walk and we see a passenger segment deviation, we can see their trunk moving, something is going on. Either it's a primary problem or it's a compensation for something else. So that will help improve your observational gait analysis ability. Inman published an article in the 1953 JBJS that I think has to be amongst the top 5 in terms of significance of everything ever published in our profession's flagship journal. And he was very focused on the excursion of the body's center of mass as a measurement of efficiency of gait. And this article has some amazing diagrams. This one shows the excursion of the body's center of mass in 3 spatial dimensions and a temporal dimension. This one diagram covers everything that we talked about as we kind of moved through our normal gait lecture. He used what he called a compass gait to illustrate the value of multiple limb segments working together. So if you have a pelvis that doesn't rotate, a hip that only moves in one plane, and no knee and no ankle, if you walk that, the center of mass is going to have a sinusoidal excursion. If you throw in pelvic rotation and hip rotation and a knee and then an ankle, all that serves to dampen the excursion of the body's center of mass. So less potential to kinetic energy changes, which is wasteful energy-wise, less excursion. All right. One of his students, Jacqueline Perry, who I had the great fortune to be a student under and then become a friend with, took Inman's work and created terminology to describe how the foot interacts with the floor. And we still use these terms today, and these are things that you'll want to be very comfortable with by the time you finish the rotation. So we recognize 3 rockers. The first, or heel rocker, occurs at initial contact. The heel hits the ground first. That's followed by controlled ankle plantar flexion, eccentric activity of the pre-tibial muscles to get the foot flat on the floor. This is the first, or the heel rocker. And I told you earlier, if you don't have a heel strike at initial contact, no way you can have a first rocker. Next is the second, or ankle rocker. We're in mid stance now. The foot is flat on the floor. The body is advancing over the foot. And the way that occurs is by ankle dorsiflexion. This also has to occur in a controlled fashion or will fall down. So ankle plantar flexor muscles functioning eccentrically. So that's the second, or ankle rocker. Finally, we have the third, or forefoot rocker. This occurs at the end of stance. What we see is the heel rising, and it occurs just at the same time that the opposite heel touches the ground. Now, there's very little ankle movement here. What is happening is dorsiflexion through the forefoot. That's why we call it the forefoot rocker. As the limb unloads, there is passive ankle plantar flexion. By this point, though, we're at the end of the third rocker. So 3 rockers. I'm going to try to show you this. We're going to use the right limb as the reference limb. And once they get perfectly into the sagittal plane. Okay, heel strike. The foot goes flat. That was the first rocker. The foot is flat. The body is advancing over it. We have ankle dorsiflexion. That's the second rocker. We see the heel rise. It occurs just about the time the opposite heel hits the floor. We have dorsiflexion through the forefoot. And then as we unload, passive ankle plantar flexion. 3 rockers. And going back to proprioception, look how close we can clear to the floor. Incredible. So Inman focused his study of energy efficiency on mechanical work, the excursion of the body center of mass, because that's all the technology he really had at the time. We now know that we can measure physiologic work through energetics. And at the end of the day, it's probably more physiologic work that is the bottom line than mechanical work. But in typical gait, I would say that these two are pretty tightly coupled. But when you get into like CP gait, as we'll talk about, I would suggest that these two may not be so tightly coupled. We'll do that another time. So to paraphrase one of the world's most famous athletes, Muhammad Ali, motion is poetry. And I hope you've gotten a little window here into how mechanistically elegant normal human bipedal gait is. The take-home messages from this lecture are that at any point in the gait cycle, there needs to be a balance between externally applied forces and internally generated forces. In stance phase, the principal externally applied force is the ground reaction force. In swing phase, there are gravitational and inertial forces. Internal forces are generated primarily, but not exclusively, by the muscles. They can also be generated by ligaments and skeletal anatomy. The location of the ground reaction force relative to the joint centers during stance phase is carefully controlled by muscle activity and body segmental alignment or posture to optimize efficiency. Normal gait requires stability in stance, clearance in swing. Effective phase shifts from stance to swing and swing to stance. And all of this has to happen in a relatively energy efficient fashion. The modern study of motion includes the measurement of kinematics, kinetics, dynamic EMG, pedobarography, and energetics. Kinematics describes how the body segments are moving. Kinetics describes the forces acting across the joints that cause the body segments to move as they do. So the kinetics explains the kinematics. When a muscle is active, it generates an electrical potential. We can measure that with surface or fine wire electrodes. And we call that dynamic EMG. We'll talk more about that in a moment. We can measure how the foot contacts the floor. That's dynamic pedobarography, a fabulous tool. And you'll rarely see us discuss energetics. Bless you. We've had the ability to measure energetics on and off over the years, but there are so many covariables that kind of pollute the output that it has not been very widely applied in pediatric orthopedics and gait analysis, which is too bad because conceptually that is what it's about at the end of the day, efficiency. So as I said, kinematics describes movement. We typically show the gait cycle on the horizontal axis, the joint and the plane on the vertical axis. This line describes the interval between stance phase and swing phase. Recognize that this is a cycle, and by convention, we show it this way, which makes it really easy to see what's going to happen, what's happening between stance and swing, but it doesn't show us quite as clearly what happens between swing and stance. And I've long thought, and never achieved it, that we should be showing stance, swing, stance plots. I think that would show us more. We have normal data for children developing, so we can have age-matched norms for our patients. So if we think about the ankle and the sagittal plane, this is what the first rocker looks like kinematically. A controlled ankle plantar flexion. Second rocker, controlled ankle dorsiflexion. Third rocker, as the limb unloads, we start to plantar flex again. That's what the three rockers look like on kinematic data. Kinetic data includes moments, and by convention, we show internal moments since the muscles are generating those moments, and the muscles are one of the elements that we can intervene on to improve gait. Again, gait cycle on the horizontal axis, the type of moment on the vertical axis, and again, these are internal moments. And I told you about the ankle, motor number one, terminal stance, a large internal plantar flexor moment. That's what it looks like, motor number one. Power analysis is a mechanical concept that we apply to a biological system, and that's a little bit confusing to clinicians. Power analysis can tell us when a muscle is functioning in a shortening fashion or a lengthening fashion. Power is moment times motion, simplistically, all right? So when we describe power, if we say there is power generation, that tells us the muscle is functioning concentrically. If we say power absorption, it's functioning eccentrically. Now, both concentric and eccentric muscle activities are exothermic. Yet the term absorption implies that something is getting into the muscle that you're storing that you can then release. And that's a very, very small, that's quite small biologically. So clinicians have some troubles with this, and we rarely use these data for clinical decision-making. There are instances where we do, but it can be an outcome measure. So at the ankle, sagittal plane, terminal stance, we have significant increased power generation. That tells us that that internal plantar flexor moment is being generated by shortening activity of the ankle plantar flexors. And this can be a window into disruption of normal gait function. For EMG, we typically show several gait cycles. The normal timing of the muscle activity is shown by a solid bar, and then we partially clean up the EMG signal, and that tells us then when is the muscle actually on relative to when it should be on. And recognize that this only tells you on or off. The relationship between the magnitude of the EMG signal and the strength or force generated by the muscle is not linear. It's just on or off. So here, for instance, we see the rectus on in mid-swing while walking at a typical velocity. It shouldn't be on. This is a very common EMG profile for a kid with CP who has a stiff knee gait, the knee's not bending, possibly because the rectus is inappropriately firing. And if we determine that that's the case, we can lengthen or transfer the rectus to unlock the knee and swing phase. More about that later. So the modern study of motion represents a convergence between artists like Muybridge, science like Braun and Fisher, and thanks to computer technology, we can actually use it in modern medicine. And there's multiple ways to use this technology. It's a great research tool. It's one of the domains of clinical outcome. I would suggest it's a technical domain. It's a great tool for teaching biomechanics to those of us who are not engineers. And if all you saw was what we do here, you would think, oh, of course, using the data for clinical decision-making, why not? Turns out that's not the case. It's very controversial, and that will be a topic for another time. If you're going to use these data, you have to understand the techniques and the technologies involved. There are hardware and software limitations. There are modeling assumptions that might be acceptable to an engineer, but wouldn't be acceptable to a clinician. Most of the time, though, it's the other way. We're looking for assumptions and modeling that we find acceptable, but the engineer says not precise enough. So it's a multidisciplinary field, and we all work together to come up with things that work. And in the end, at this point, these are just data. And we still have to interpret the data. And so gait data enhances clinical judgment, but at this point does not replace it. It might be at some point in your professional lifetimes that machine learning and AI with enough ground truth data will start to truly help us interpret the data. But it's quite complex, and there are multiple factors that we have to throw in. So at this point, the data doesn't make the decisions, we do. All right, so qualitative and quantitative gait analysis are complementary. All of this is based on a foundation of normal gait. And almost whatever type of orthopedics you do, you'll want to be able to perform decent observational gait analysis. And again, if you have a good understanding of normal gait, off you go. The next time we get together, we're going to use this same paradigm to consider how gait is disrupted in children with CP.